Introducing yourself, Sean.
Bonjour, my name is Sean Middleton. I work in behavioral health home. I am probably transitioning very soon to doing more the behavioral health work as I'm applying for my license finally after being kicked down the road to do that by Dr. Mason.
And with that, Dr. Mason, would you introduce yourself?
That was a long time to figure out how to unmute. So I apologize for my lack of skill. My name is Gail Mason. I have a PhD in clinical psychology and I'm the behavioral health director for NACC, Ojibwe Three Fires Council out of Thunder Bay, Canada.
Rich and Tina.
My name is Tina. I'm the HIV case manager here at NACC.
Thank you. And I'm Kari Rabi. I'm family practice and addiction medicine physician here at NACC as well. So I'm going to go ahead and start just with our agenda. So this is, of course, the Midwest Tribal Echo. We've already had Mr. Middleton do our prayer and land acknowledgement. I'm doing the introductions and agenda. I'll go through the Zoom guidelines briefly. Tina's going to do our announcements. We're excited to have our own Chyna and along with a team to giving our didactic today. We don't have a case presentation planned today, and then we will close. And of course, in Zoom, please let us know who you are. Introduce yourself in the chat function with your name, title, organization, and email. You can also right-click on your name in your screen and update your name for that. We always prefer when people turn the camera on so that we can see you. It just makes for a better discussion. And we also ask that you mute your microphone when you're not speaking. If we do hear some noise coming from your direction that is not intended, we will mute you. So please don't take offense if that happens. You can use the chat or hand raise function if you need attention. And as always, please no protected health information during the echo. Tina, could you do the announcements, please?
Yeah. So just a reminder that we meet every first and third Wednesday of the month from noon to 1 p.m. The next echo will be on January 5th of next year, and Dr. Stately will be speaking again about historical trauma. January 19th echo has not yet been scheduled, but I will keep everyone updated about what's to come. Another echo that is also under the Stratus Health umbrella is the Opioid Use Disorder Education and Treatment Echo series with Dr. Heather Bell and Kurt Devine. That happens on the first and third Tuesdays from 12:15 to 1:15. Please reach out to me if you want some more information about that. And then so case presentations are a great time for people to actually bring like real life scenarios to these echoes just to talk about challenges and sort of receive feedback from other professionals in the field. So if you have a case presentation that you want to bring to the table, you can contact me, just let me know. Usually these case presentations happen at the end of the didactic. We haven't had case presentations, but we are definitely still wanting to incorporate them. So, and then these sessions are also like eligible people you can get CMEs, continuing education credits. So in order to get that, you would have to fill out the survey that I send out in email after the session. And so if everyone could just introduce themselves in the chat and just drop your email, name, organization, and your email in the chat, that would be greatly appreciated. And if you have questions about CME stuff, please feel free to reach out to me, and I can connect you with our partners at Stratus. So yeah. And I'm going to stop sharing and hand it over to our presenters now.
If you wouldn't all mind introducing yourself before you start, that would be great.
Hi, I'm Chyna Pfeiffer. I'm a peer recovery specialist at Native American Community Clinic. And I've been working here for about 3 years, working with patients in the outpatient program and in the medical and MAT, and then also do outreach and harm reduction related stuff.
My name is Jan Johnson, and I'm a social worker on the addiction medicine team at the M Health University campus. And I've been working at both the university and the West Bank campus for almost 15 years now. And I've actually worked in all the medical units, and most recently in the emergency department for a couple years. And then in April, began on the addiction medicine team.
My name is Pham. I'm an internal medicine and pediatrics doctor. I spend half my time at Cook Clinic, the other half at the hospital service at the university. Most recently, board certified in addiction through the clinical pathway in the last few years. Also do a bit of work around diversity and equity inclusion at the university, particularly with our trainees there.
My name is Ryan Kelly. I work at Cook along with Coop, and I also am an internal medicine doctor at the East Campus University Hospital, as well as an addiction provider there. I think Ku is going to talk a little bit about addiction teams across the country.
We can do that. I was going to do a little bit more later, but I think this team is a very unique team. I think in the Twin Cities and probably in Minnesota overall. I think historically we've been kind of doing this kind of a hodgepodge patchwork, particularly more in the outpatient setting and a little bit in the inpatient setting. So this will give you insight what we've been doing at the university and a little bit on from the Twin Cities perspective overall.
We don't have anything to disclose. As we all are well aware, housing, social inequities are leading to terrible outcomes for people who use drugs. This slide is specific to drug overdoses, and we know things are getting worse. Isolation, COVID impacting this. And we talk a lot about overdoses, but people who use drugs, as well as people who overuse alcohol, are at huge risk of other medical complications that lead to hospitalization. And as we're going to talk first about kind of the current state of hospitals and support for people who use drugs and need help with alcohol use, and then talk more about our team.
Objectives. After this presentation, you'll be able to list 3 challenges people who use drugs face when seeking healthcare, and describe one way that a peer recovery specialist can improve linkage to care once discharged.
So yeah, I mentioned before that historically there has not been a lot of standardized way to take care of patients with addiction in the hospital setting. And this is probably true across Minnesota, particularly in the Twin Cities. Probably the most mature group in terms of inpatient treatment of addiction has been NHEDPN. They've been together as a group the last 5 years. There's now a group at Abbott. They're kind of doing ad hoc. A lot of them are emergency medicine doctors. And there's a little bit growing up through regions too. Ryan, I would say, has been the forefront of this. He had been doing addiction consults on the side for the last few years. And as a group, we realized, because Ryan and I have been doing so much addiction work at Cook from a primary care setting, we needed to make some sort of transition happen in the hospital and to give support to those patients too. And so this group was formed through a grant, but to give you a sense, the university is a little bit of a weird system because we have two campuses. There's the West Campus and the East Campus, and historically they have different cultures and how they do consults overall. And most of the culture is different because there's the medicine service and there's the psychiatry service or the behavioral health line. The strength of the behavioral health line has always historically been on the West Campus on Riverside. So they have actually psych inpatient there and a detox there, which does not exist on the East Campus. But all in all, what has happened in the past is that they, on the East Campus, often what happened is our psychiatry folks would take the burden on the addiction consults. They are not specifically addiction trained. And then on top of that, what they do, because their service is so burdened from other consults, they're kind of more of a one and done consult, meaning that they could get consulted, they'll see that patient for that day, and that is it. They don't do any follow-up care at all, which means there's no follow-up care in terms of outpatient or discharge, and they don't really build that relationship with the individual overall. And there had not been any focus from the standpoint of medical management, medications, if we're talking about methadone or Suboxone or buprenorphine, and it wasn't ever a team-based approach. So they didn't have anyone else helping them, whether there was a care coordinator or a social worker too.
And there are, between the two campuses, and this is just in the medicine units, not in the mental health and addiction services on West Bank. I mean, there are, 70 social workers and 40 nurse care coordinators who, were being consulted to do chemical dependency assessments alongside, with psychiatrists and to provide resources. But they're also tasked with so many other things, as well as mainly discharge planning. And especially in the pandemic now and with the capacity issues, there's so much pressure for discharge planning that a lot of these visits with the patients were, I think, kind of brief and hurried, even though, they didn't mean to do that, but it was just, there's just so much going on and so many patients to see with a lot of pressure behind them too. So.
And so what that means for people, and this is not an inclusive list, but for people who are in the hospital and are struggling with substance use, if we're not identifying that, if we're not offering medications, if we're not providing spiritual, cultural supports to help people handle the really stressful situation of being in the hospital, if we're not addressing bias and racism, that leads to self-medication in the hospital. If harm reduction isn't discussed, if people aren't educated on how to inject drugs in a safer way, if people don't have a place to go anywhere, if the hospital doesn't have a way to link someone to follow up, then that all leads to disastrous outcomes that we'll talk about in a minute. But let's say you do get someone out of the hospital and try and link them to clinic. Well, if you don't have a way to get to clinic, if you don't have stable housing and you don't have a phone, it's difficult to make it to clinic. When you're living day to day, thinking about a future appointment, that's not compatible with someone's goal at the moment. But let's say you do make it to clinic and you didn't have access to hygiene, and so you're sitting in the waiting room and security is monitoring you. This just leads to continued bias, ongoing trauma. Let's say eventually you do get in front of the provider. The medications need to be sent to the pharmacy. You have to get to the pharmacy. You need to have identification, etc. And so then Chyna's going to talk more from her angle and her experience about how this impacts people.
So in these settings, patients can experience bias and stigma. Providers have lack of knowledge of substance use disorder, and miss or underdiagnose them. There's undertreatment and lack of patient-centered evidence-based care. lack of cultural appreciation and support, and lack of linkage to services. You know, maybe give them a printout, but sometimes, you know, it takes, there's more barriers to actually like connecting to other services, which can make it difficult for patients to do.
All this adds up into people leaving the hospital without being treated with respect and before they're medically ready. And so, and you know, hospital lingo, that's called against medical advice. And so, you know, we've got the data on who leaves our hospital against medical advice. And so all comers, a little bit less than 1% leave before medically they're ready. It's 0.9%. But if we look at who is admitted, you know, who are people who inject drugs are admitted to the hospital, about 5% of them leave against medical advice. But if you break that down to look at how they self-identify racially, ethnically, then you really start seeing how historical trauma, racism, et cetera, can impact people. And so this is looking at against medical advice, depending on how people identify themselves. You can see the huge disparities here. And Dr. Pham is going to talk a little bit more about this, or Kuro.
Yeah, and I think this table highlights the systemic racism that's going on within the university system. I wouldn't be surprised it's in other systems too. A lot of this is rooted in the fact that there's very little training around stigma and bias in the first place. So I think the concepts of harm reduction and working with people who have drug use has been really minimal. From the perspective of me and Ryan, our medical school training around addiction, that was literally almost zero. We literally didn't have any training also during residency. This is all from our own clinical experience. So imagine the system of providers going through and taking care of these individuals. On top of that, conversations about diversity and racism, particularly for our older faculty, has been a tough topic for people. I mean, we're talking about more about it because of the murder of George Floyd 2 years ago, but it was pretty silent in that conversation, I would say, throughout the entire medical school. So racism plus stigma and discrimination all adds up to the patient experience. And this is not just from faculty, it also involves our staff. It involves the entire experience for the patient. So it's not uncommon for our patients to feel like they're in a prison once in the hospital and their desire to leave the hospital.
And so, you know, a little education on the provider side. When Ku and I, we were asked by our clinic, Kook, to kind of be involved in the initiation of Suboxone Clinic in 2015. And that little bit of education, we realized what a terrible situation the hospital was. And then, you know, shortly thereafter, you know, we started trying to support people in the hospital. And eventually that led to Simona and NACC connecting me to Chyna. And Chyna helped educate me on the different ways that we can support people. And that led to searching through the evidence and finding other academic centers across the country that have an interdisciplinary team that are able to better support people. And we applied for grants and now have a team we're going to talk more about. That includes Chyna as the peer recovery specialist, includes Jan as a social worker, it includes Ku and I. And besides making the hospital experience better, we're really invested, as we'll talk about, in linking people to whatever services they're interested in once they leave. So now we'll go through each of our positions and what we do.
So a peer recovery specialist has some formal training, but mostly utilizes their lived experience with substance use and recovery to connect with and support others wherever they're at with their substance use. The power dynamic is much different than conventional therapeutic relationships. It's more like two equals with similar experiences connecting in a mutual way. Through my own experience, like using different resources in the community or through my work at NACC, connecting with other organizations, I'm able to connect patients to resources in the community and kind of walk them through the steps involved with that, connecting to them. I can advocate for patients' needs or concerns by introducing the patient's point of view with healthcare decisions. I can help patients identify and work towards their goals. A lot of times, or sometimes, people might just assume that the patient's goal is sobriety, and this could be a missed opportunity to have conversations around harm reduction and or safer injection practices.
I think from the medical provider standpoint, and I want to make this really important, that it is very much a team effort. The medical provider just provides actually one small aspect to that person's care. The other part I wanted to make sure is clear is we are consultants. So there is a primary team that's taking care of these patients, and they're asking us for help here. And each primary team may have a different approach to the care of that person. So they might be on a surgical service, they might be on a medical service, they might be on a transplant service. And the way they approach that patient might be different. And our job as medical providers or the consultant is to either number one for me always to advocate for the patient. But number two is understand what the needs are for the team. And because we're a really new team, our job is to make sure that we kind of fit into the equation for the care of that patient for the medical team. So sometimes it's all about really engagement and having discussions with patients where they're at, where they're ready, because my job is never to force them to be on sort of treatment at all, but really kind of understand what they want. And then number two, if they're ready for medications, I will provide that for them and figure out ways that they can continue that medication as an outpatient too. The other part I think that's been important for us as medical providers is we've been a network part of the entire university. And that means that providing larger discussions with staff and other teams, how we frame the care for our patients. How do we take care of patients in terms of drug screens? How do we take care of patients when we're talking about when they actually are in the ER, or we're talking about police search? All these things are part of our discussion, not just the clinical care. So it's a whole patient experience for them.
Jan's likely going to talk about this more, but a big part of what we do as well is linkage. Before our involvement, what would happen is someone's in the hospital, maybe they'd be seen and offered Suboxone or methadone or medications to help alcohol use, cravings. But they would get a piece of paper saying, hey, go establish primary care somewhere. And if someone lived outstate or even out of state, there was even less resources. And so a lot of what Jan and I do is find out where someone stays. If someone is outstate, if someone's on a reservation in another state, if someone's, it doesn't matter where they're at, really helping that person find out what the resources are where they currently stay and make it as easy as possible for them to continue their medications or to continue their, whatever their goal is to help them get there. Some of the relationships we've built, working closely with the team on Homeward Bounds, obviously the American Community Clinic in Kook, IHB, if someone's in St. Paul, Minnesota Community Cares, and often if someone is interested in chemmed up treatment of some sort, really having Chyna help our either our LADC team or an outside LADC team help come up with the best fit for that person.
So I'll speak to the social worker role. And again, like Ku had mentioned, our team is a consultant team. So the patients will have unit social workers as well that will eventually come into the picture for discharge planning. But my role, of course, as we know, it starts with an assessment. This is more not just usually in one visit, but in multiple visits, kind of going slow with the patient and focusing on building that rapport with them. In my role, I get to be really truly supportive. And so what I mean by that is that the hospital staff are dedicated to caring for the patient, but it also kind of means that they're going in with an agenda. Like the nurse goes in to give a medication, the social worker goes in to talk about discharge planning and get that started, or it's time to do wound care. But when we get to go in, it's really about just working on engaging with that person if they feel up to that, and getting to support them in various ways. And so we identify what psychosocial stressors they're undergoing, what their goals are in relation to their health or their psychosocial situation, what their support network is. In any visit, I don't do like a 45-minute counseling session like you would go to a mental health clinic. Usually patients just feel too crummy for that. And there's just, there's nurses around hanging the IV bags. There's just so much going on that just doesn't work. So my counseling are more techniques in my supportive visits with patients. One of the favorite parts of my job is if somebody is identified that perhaps, a lack of income is the issue, and then of course the lack of maybe housing, I will offer to, here, not only to give information, but I'm happy to sit with you and call Social Security together with you. So I like to spend as much time as the patient wants me to, at their bedside, helping them fill out these things. This is, again, all patient driven. If this is something they want to do and services that they want, I explain that first so that they can kind of pick and choose what they want to work on for their hospitalization. And then I reach out to other hospital staff, the primary team, to kind of let them know, what we're working on with the patient. I will coordinate care with, case managers and other outpatient providers. If that's something the patient wants me to do, I'm happy to do that with confidentiality. Of course, the patient signs a release for that. And then a big part of my job is that linkage to outpatient care. And so in getting to know them and what they're looking for, we can then set them up with the right resources and plan, at the end of their hospitalization. And ideally, this is done with a warm handoff, whether that's me calling with the patient and kind of introducing ourselves and what we're hoping from that other outpatient care provider, or it's me giving that person a call and getting to know both the community supports and what they have to offer, but letting them know that the expectation is, or the hope is follow-up. I also want to mention too, that when I meet with patients, so in the state of Minnesota, I forget the exact percentage, but it's a very, very high percentage of social workers are white and female. And so our visits tend to be a little bit more kind of slower paced to build a little bit more rapport and trust, because a lot of patients have interfaced with other social workers in the past. And I'm not sure, sometimes they tell me the type of experience that they had, other times I'm not sure. And so it's really important that I really kind of go based on kind of at their speed and keep in the forefront of, of my own race and how that might play into their experiences. I'm starting to do a lot of education and advocacy. I'm now part of the orientation process for any of the new hires for the nurse care coordinators and social workers. I'll do education about our consult team and how we fit into everything at the university hospital, but I'll also talk a lot about Chyna's role as peer recovery specialist, because for most of my colleague of the nurse care coordinators and social workers, they're not familiar with that role. And then I'll do education too about symptoms of SUD and diagnosis. And then I also hand out information on Words Matter about stigmatizing language so that we make Fairview more inclusive to patients experiencing a substance use disorder. Our team does a weekly Zoom meeting, and we network with other community supports. And if we think that they may be helpful or beneficial to our patients just as a whole, or someone that we want to start working with for or get to know more about, I'll invite them to our weekly Zoom meetings, or Ryan or Ku will. And then I get a lot of calls throughout the week just for case consultation and helping teams identify who to include in the patient's care, when to consult us, how to manage their symptoms, and then different resources that may be helpful. Also, when we meet with patients, we also let them know about the chaplain services that are on site at the hospital. We've really started increasing our kind of partnership and working with chaplain services to provide more spiritual, cultural, and emotional support with our patients. So much so that we're in daily communication with them. We oftentimes run our list with them. And sometimes we'll like co-visit with them, or, me and a chaplain will see a patient together if that's something that the patient wants or that we may find helpful.
And chaplain will also offer smudge to patients. And we now have a sustainable process to increase the availability of smudging for patients in the hospital. And this increase led to a project to educate nursing staff on the importance of smudging and other cultural supports for patients.
So there, as we know, there's a lack of system addiction support. Some of the challenges we've highlighted here is the lack of education on substance use disorder, the lack of harm reduction specialists, a lack of culturally appropriate treatment for chemical health, and punitive and stigmatizing care. And so some of the solutions that that we've identified is a peer support that has just been crucial in providing that type of support to patients in the hospital that they haven't had before, improving linkage to care for more successful transfers, and discharges outside of the hospital, increase access to medications, considering chaplain consults, improving the language we use. I wrote here patient care agreement, and I wanted to highlight that because oftentimes in the hospital setting, when a person is having symptoms or challenges with substance use disorder, it could be a variety of things, but it could lead to the staff wanting to approach the patient with what we've in the past historically called a behavioral contract. And that oftentimes in a behavioral contract, it really puts a lot of all the onus of responsibility and expectations of change on the patient, where in a patient care agreement, there's not only what we're asking from the patient, but also responsibilities that the hospital is to provide the patient as well. So it's a more mutual care agreement. And ideally, all of these things would lead to improved patient and healthcare team satisfaction.
Before we run through a patient example and then see what questions people have, I think one of the most important parts of having an interdisciplinary team is, as we've talked about, building relationships. And so because the university is this large academic health center with advanced specialists, and so people are sent from all over the state, even out of state, we're building relationships with heart surgeons, with the cardiologists who support people whose hearts don't pump right anymore, with the liver transplant team, and using, providing education to these providers is kind of changing very slowly, but still changing people's approach to people who use drugs in a way that I think is more human-centered. And we have a long way to go, but it's been pretty rewarding.
Yeah, and I would also add that from my perspective, I've learned a lot from Chyna and Jan too. Definitely having co-visits with them have opened my eyes in terms of their discussions and what can happen in that space. So for me to go by myself, it's definitely a different experience when I'm going in with Jan. I haven't had a chance as much with Chyna, because Chyna, the great thing is she comes in after hours. It's a totally different space for our patients too. And I think if it lets them feel a little bit more of like, this is more casual, a connection to, and less medicalized visit with them too. And so we are touching spaces for the first time I think our patients have not thought about, the hospital system has not thought about, and it is causing a lot of growing pains, to be very honest. People are asking questions. Why are you approaching patients this way? Why are you allowing patients to use drugs? And so it's hard questions, but questions that need to be asked and talked about. And so we are learning to be gentle in those questions and pushing people in a direction that we see that is more patient-centered and more community-centered for the first time.
So we're just going to run through one example of kind of how we worked as a team, and then just see what questions people have. So we had there's a patient who was flown in from out of state who was very, very sick. So she had endocarditis. And so basically bacteria from her skin from injecting it into her blood and it infected her heart valve. But she was also in late second trimester. And so she came in and had an emergency C-section. And then she was separated from her baby. Her baby was on West Campus, where the neonatal ICU is. And she was on East Campus, where the adult ICU is. And so Chyna's going to talk a little bit more about how our team developed a relationship and kind of how things went.
So when she was flown in, she had been incarcerated before that. So she got sick while she was in jail, and brought here. And then so she's far away from her family and supports. She's going through her own healing, health issues, while her baby's in the NICU, and he was born so early, like it was kind of touch and go, like every day it was just something new was happening, something big, and there was a lot of stress and anxiety and shame, guilt, and so eventually, after she was able to be discharged from the hospital, so we were trying to figure out what was going to happen with her and baby. Her insurance was from North Dakota, and there's a an inpatient treatment that's on the West Bank campus where baby was, but her insurance would only cover part of it. They wouldn't cover the lodging part. So during a care conference with her social worker and the baby's social worker, we discussed, should baby go, should they go back? Should they transfer baby to a hospital in North Dakota because of the insurance issues? And then she's got some more supports there, but she had told me that she wanted to stay here for treatment. She thought that the programs here were better. So I just brought up the fact that transferring baby from one hospital to another could be disruptive, and brought up the you know, the supports in the area, and thought maybe we could contact her tribe and see if they could help cover the portion that the insurance wasn't covering for her to be able to go to treatment here. And the social worker did reach out, and the tribe agreed to help out, and so she was able to do her treatment and be able to, because it's in the same building as where baby was, she could go and visit baby daily, have the skin to skin time. And yeah, after she graduated from treatment, he stayed nearby, and was able to visit baby daily, and was close enough that she could walk to Kook, to check in with Ryan for Suboxone, and meet with me at NACC for one-on-one, support. And eventually, baby was able to be discharged, and they're now back in North Dakota, and doing well.
Trying to imagine what this person would have experienced at the university maybe 10 years ago if they had been admitted without our support. And I would imagine that this person would probably not get enough pain medication to deal with the pain they're dealing with emotionally and physically. And I think all the support staff, particularly Chyna and Jan, helped so much in learning more about this person's story too. I think often the surgical services are so busy, they don't have that time because they're on to the next patient, the next OR visit, to really learn about this individual's narrative and life experiences. And the fact that she got to see Ryan as outpatient, that would have never happened previously. I think this person would maybe be connected to some sort of treatment, but it would be on their own to find that treatment program.
I just get emotional thinking about her and how she's successful in meeting her goals right now. But maybe we do have a couple other patients we could talk about, but maybe we'll just open up the questions and see what questions people have. See if I'm sure there's people who have had patients, family members, people they know who've had terrible experiences in the hospital. I mean, I think let's talk about whatever comes to mind. Maybe I'll stop sharing my slides so that way we can all see each other. Maybe I'll just vocalize Sean's question from the chat. Sean, you had wondered what were the restrictions on becoming a peer recovery specialist, and I think Chyna and Valerie both kind of weighed in. If either of you guys want to kind of verbalize your answer for everyone.
Yeah, I'm just seeing, that Valerie was here. So she was, I think, didn't you, you did some of the training for my peer recovery coach training. Anyway, but yeah, so that was through the Minnesota Recovery Connection. And so from what I understand, they suggest like a certain amount of time of being free of problematic substance use. But so say if, so the Minnesota Recovery Connection, they offer grants to help, cover the cost of the training. And in return, then you would do a certain amount of volunteering at the Minnesota Recovery Connection. And in which case, then I think there's a different amount of time expected of sobriety.
I don't know if I can be heard here. I know I don't have a camera, but I don't know if this is working. Hey,
We can
Chyna.
hear you.
Hey.
Okay. Yes, I was with the Recovery Corps working through Minnesota Recovery Connection, and that's why I was present at the training in Brainerd, which was also partially facilitated by Wellness in the Woods. And there's a lot more happening with peer training, both at Minnesota Recovery Connection and at the Twin Cities Recovery Project. And you nailed everything. It's when you go to apply, you'll be considered on a case-by-case basis. It's more about quality of recovery versus quantity.
Thank you. Anyone else with other questions or comments?
I'm always curious about the barriers within systems, because I think that, you know, from being outside of a major hospital system, it seems like I think to be honest, M Health does probably the best job of this sort of thing, but it just seems like there's so many departments and it's so siloed, and, you know, different departments are siloed from each other, and it becomes somewhat impenetrable to the outside. So this is what's like kind of so amazing about the connection you've made with, you know, Chyna, and putting this team together and sort of really trying to move within the system. So I'm just curious to hear a little bit more about that, and the sort of barriers that you're hearing from providers, and how the hospital teams are perceiving their own stigma, I guess, or how they're stigmatizing patients.
Maybe I'll speak first, and Ku, you can pick up the pieces, and Chyna and Jan, you can chime in. I think, you know, because any hospital that you're at any given moment, you can be treated like crap. And it doesn't matter how nice some people are, one person with either, lack of education, either intentionally or accidentally, being racist or biased ruins everything and ruins your experience, right? And so, I think your entire country or world has a long way to go, period. But when things are really siloed, Fairview is like, I don't know how many hospitals that is, Fairview merged with Health East. And so where we're struggling right now is to have a long-term sustainable team. Who do we ask to support us? Where do we go? It's not our specific hospital. It's like the much higher ups that control all the hospitals. And, so I think each of the hospital systems in the Twin Cities are struggling with that right now. How do we make a system to support people in our specific hospital that can be sustainable? I think really where the money should be going is to have more peers. But I also think, Chyna, if you were contracted at Fairview and could only work at Fairview, that means you wouldn't see anyone at NACC, you wouldn't see anyone at COOC, you wouldn't see anyone who went over to Abbott, right? And so, how do we create a system where it's more of a subcontracting relationship? Those are just my thoughts. Chyna, Jan, what do you guys think?
I think the one thing that the system doesn't see is that they see dollar signs first. And addiction medicine doesn't make money for the system. We're a support team. We're there for the patient. We are there as advocates. I think we're often maybe seen as like a team, like the palliative care team, are teams that really, they're a support system, because if they don't exist, the whole thing falls apart. And I think Fairview is learning about this for the first time. And it's hard to have those conversations because they go back to the dollar sign again. It's like, what money are you making for us here? And it just doesn't work that way. And so I think that's a barrier for us. The other barrier is, I agree, the silo part is when a patient comes to the ER experience is very different from the medical experience when they're in the room with a medical team or they're in the room with a surgical team. We don't have a standard approach to this. We're all doing this so differently. It sends so completely different messages to the patient, to that family. I mean, one bad experience means I'm not going to go to the hospital at all anymore. And that's not what we want to do. We want to be a welcoming space. And so we need to learn how to make these welcoming spaces more available in all different parts of the hospital.
And then simultaneous, we need to have Jan and Chyna kind of peer support this in the greater good and get this out to Bemidji and other regions that have a high population of folks who could benefit from this, so that we could like impact people on a great work. And I appreciate we're touched. I'm touched.
And to speak to your point, Ku, about the dollar signs, the interesting thing about that is that the highest cost patients in the Medicaid system right now are exactly these patients. And if you know, the problem is the system itself is siloed, where the people who are, I'm sorry, I'm single payer system. I mean, if you were really looking at dollar signs, you would be looking at these are the patients you would be focusing all your resources on.
Very much agree.
I just wanted to bring up an example. I've been working with folks for the last 7 years at NACC, and I've done a lot of care coordination over the years, and I'm still connected to a few folks that are homeless and still actively using. And a big piece that I'm seeing is that, the utilization of the ER systems. Now, I get a better picture because I'm thinking of one specific person who reaches out and calls me every time he's in different hospitalization settings, treatment settings, because it's having to explain over and over what his needs are. Whereas like he knows I have worked with him long term, and it's not like starting over. So I think a big issue is that if we know these folks are coming in and utilizing the ER over and over, there is no looking back and seeing like what was it that patient expressed as what they were struggling with last time they were in. So there's no continuity there. And even when it comes down to, I had one individual who was approved for like waivered services for housing, for, and there's only a certain amount of time to access that care. And it was through Hennepin County, but yet like Hennepin County Medical Center didn't know that this was in the process. So there's a lot of pieces that are missing, and those folks just continuously get lost, with that gap in those services because there isn't that communication. So I think it's not necessarily feeling disrespected by one specific person. It's that I continue to come back, and I've expressed at one point what my needs are. And then when I come back another time, people are asking me the same questions. And now I feel frustrated because what I need I'm not getting what I need. And so I think that's a big piece when we think of when I think of Chyna being out there, is she knows these folks, she knows these folks either in outreach or, in the community, and the importance of establishing that community connection where there isn't, this person is always here. I can go to her prior to going to the ER maybe, or when I do end up in the ER, I can reach out. So I think of that harm reduction as, having a plan and feeling like I'm empowered to, make those connections, have a plan, and have someone in my corner who understands my plan and my care and what I need in a way that I don't get frustrated, And so we have a lot of folks. So when I think of harm reduction, for me, it's bigger than just use. It's improving health and reducing, that the risks and consequences, I guess you could say, of your health declining. So it is like a diabetic, someone who's diabetic, who needs a pair of clean socks. Chyna brings stuff to the hospital all the time for a lot of our clients. And I see harm reduction as also reducing that anxiety of being in the hospital, bringing them things that they can do while they're in the hospital so that they can feel calmer, and just managing that while they're in there. So I think it's just I just encourage everyone to think bigger when it comes to harm reduction, that it's not just focusing on the use, but what we can do to help support people learn some skills in coping with the situations that they're in at the time that they're in those situations. So it's such a process. And like I said, I've worked with someone for the last 7 years who is still using, but it's like you know, accessing basic needs and reaching out is a huge part of that harm reduction process, and understanding and knowing how we can support in a very meaningful way and understanding those person's needs. Sorry, I went off on a tangent, but I'm passionate about this as well.
Oh, I wanted to point out too, Simone, I feel like you said that so well, because what I've noticed too, I think at the heart of harm reduction is building a relationship. And with our healthcare system and all these ED touches and whatnot, it's so disjointed. And when things are so disjointed and they're seeing different people all the time, there's just an inability to form that relationship, to really get to know that person, so that that person can feel like they can say what they need and feel like they're going to get what they need back. So.
Yeah, and one of our goals have been breaking down the walls of our institution. So often we've been to Little Earth, we've done roundtable discussions, talking circles. A couple of weeks ago, we were doing CPR training, Narcan training at Little Earth. We brought in a mobile health clinic initiative too. So there are certainly, I think, ways where we are being more relational, community-centered, being out there with our faces, so people do trust us and know that we're there for them.
Thank you so much. I see that we're running overtime. I just want to be respectful to everybody's time on this. It has been so great having you guys coming and talking about this. It's like, it's really nice to see exactly what Chyna is up to, and she's over at M Health. And you know, sort of helping to take down some of these barriers for our patients as they go into those larger systems. Any last comments before we wrap it up from the team? Thank you so much for joining us. And as our next is Dr. Stately, our next presenter.
Yep, on January 5th. So
Great. Thank you
thank
so
you,
much.
everyone.
Be safe.
Bye.
Happy holiday.
Happy holidays.